Good afternoon, everybody. Hello and welcome to the fourth HPS presentation series webinar. This follows HPS presentations on surgery and anesthesia, Uganda, monitoring and evaluation, and the Who Safe Surgery checklist. Recording of these webinars are available on our website and our YouTube channel. So today we're going to be focusing on the health partnerships working in the mental health field. So you should all be able to see our screen. Can everyone see our screen? Oh, you won't be able to. Sorry. Can everybody see our screen?
Go to webinar.
Pardon?
I've just got
Sorry.
You can't see?
No, I can't see.
my screen just says connected to go to webinar, get your own go to webinar.
That's the same as ours.
Oh, right. Okay, just bear with me 1 second. So they're not able to see our screen.
The broadcast is now starting. All attendees are in listen-only mode.
Okay, so you should all be able to see our screen now. So the PowerPoint presentation and the recording will be available after today, and we intend to post the recording on our YouTube channel in case you have any problems with connectivity or in seeing the slides. So we will have some some time for questions at the end, but in the meantime, if you'd like to let us know if you have any problems with the audio, please let us know through the typed question box and we will try and address the problem. So my name is Paris Thuo and I'm the HPS Programs Officer, and I'm joined by Sophie Pinder, the Evaluation and Learning Officer here at THET. So we're here to introduce today's presentation and hopefully ensure that the technical slides side of things runs smoothly. So there are many health partnerships working to tackle mental health issues across Africa and Asia, with currently 7 ongoing HPS projects focusing on mental health. Health partnerships are playing an important role in delivering essential training to health workers in mental health and providing mental health services. Today we'll be hearing about the work of 3 different partnerships that we think excellently demonstrate the value of this work and will hopefully allow for shared learning among those working on mental health and further field. So I'd like to introduce the first session for today, which will be delivered by Chris, and Tanzania Link Manager, and Claudine, Substance Use and Mental Health Clinical Lead at the Central Northwest London NHS Foundation Trust. They are delivering the Strengthening and Substance Misuse Interventions project at Mirembe Mental Health Hospital in Uganda. Tanzania, excuse me. In collaboration with Mirembe Mental Health Hospital and the School of Nursing. I will now hand over to Chris and Claudine.
Hi, can everyone see my screen? Hello? Can everyone see my screen? Oh, right.
Not at the moment, Chris. I've just got connected to, yes, got it up there now.
Well, all I can see is me, actually, so I need to go with me. Okay, and slideshow on the start. Okay.
Perfect.
So you can all see that, can you?
Yeah.
Right. Okay. I am the Tanzania Link Manager, and we have had a link with Mirembe Hospital for the last 7 years. Our current project with them is actually helping to strengthen their substance misuse services. So our presentation today is going to be covering these areas: a brief introduction to the Tanzania Link, which I've just done, something about the grant that we have from THET, and 2 components of the project that we're working on at the moment. These are just a few photographs of Mirembe and the School of Nursing at Mirembe, just to give you an idea of the sort of environment that we're working in. It's all fairly basic and primitive, but we're working with them and they're doing a fantastic job over there. With very few staff. You can see that for 600 to 700 patients, they've got very few staff to actually work with. Substance misuse was identified as being a priority when we first started the link back in 2009, and it's very much a priority for the Ministry of Health as well. A large proportion of patients who are admitted into Mirembe Hospital have substance misuse either as a primary diagnosis or a dual diagnosis. And there are high relapse rates for patients when they're discharged because of very limited community support. And when we first started doing this particular project, there was very limited knowledge amongst staff to actually work with people with substance misuse problems. However, within the hospital, there's been a developing culture of service involvement, and so that's been very much a contributor to this project. These are a couple of pictures of the new unit, which is due to be open fairly soon, and so there's a lot of pressure on Mirembe to actually get this unit up and running and for us to complete our project with them. So these are the 4 different areas of the project that we're working on at the moment. One is about staff training that we're going to be talking about. We're also going to be talking about the income generating project, but there are 2 other components, one which is about developing peer support and also about public education and engagement. So I'm going to hand over to Claudine now.
Thank you, Chris. Okay, so we first went out to pilot some substance use and mental health training in November of 2014, and it was really to get a sense of what was the knowledge base for staff attending the training, what were the areas that they wanted us to focus on, and to try and bring something together that was a sort of an overview, but it started to give a real sense of how to support, how to identify, assess, treat people with mental health and addiction issues within an inpatient setting. We thought that one of the best ways to sort of move the training forward would be to look at identifying 12 champions across the hospital from a range of different professions, so that would help with the level of sustainability for the project. And the aim for the champions would be that they would be given some enhanced sort of skills and development training, and they'd be responsible for the training of future staff, and they'd also have some role in leading on other parts of the project, namely income generation, peer support, as well as ongoing dual diagnosis training, and in ensuring that the project would be carried whether we're there or not, and to make sure that it was in partnership. Next slide. Thanks, Chris. The main components of the training, therefore, were looking at the way we kind of delivered the training. So we had 2 days of training in relation to substance use in mental health, looking at the main substances that are of an issue, certainly for Tanzania. So we looked at alcohol, cannabis, opiates, and other substances, but those 3 were the main substances that we focus on in detail, because they are the main substances that present for the hospital. And the way we sort of put together the package was to look at formal presentations by ourselves that combine sort of medical and psychosocial interventions, so things like motivational interviewing, relapse prevention ideas, group work, engagement, assessment, a number of things. We also looked to try and incorporate some pre and post training questionnaires to try and establish baseline before we started training, and also to kind of look at post-training, how important the issue was and how confident people felt after. In terms of assessment, to try and get a sense of how well the training material stuck, if you like, we also had a couple of tests, post-training sort of quizzes, and sort of like a basic kind of exam or a test with a number of questions that focused directly on the content that had been delivered to see how well information had been retained. Next slide. Thanks, Chris. I can keep talking without the slide if you like. Yeah?
Okay, there you go.
Here we go. Okay, so the outcomes to date. So we, again, from that pilot originally in 2014 in November, we adapted a training package that was, again, 2 days worth of training. and then an extra day for champions. So I'll run through this slide. So 11 staff received the initial 4 days of training, so that's 2 sets of 2 days. 1 for champions and 1 for just general staff. 14 staff have received only 2 days of the training thus far, and they're going to join the next cohort for when we go out in November, just to make sure that everybody is getting the same amount of training and exposure to the same kind of ideas and clinical concepts, so that everybody's working from the same page. Our champions are ready to lead on training of the next cohort. So in November this year, what happens is that we go out, and basically me as a sort of chief facilitator, I'm actually going to be in the room in the background while they deliver sort of train-the-trainer style training. Over the course of delivering all of this training, it's been vital that we translate a number of, well, all of the information into Kiswahili, and although that's been a massive task, that's something that we've identified as really important to have information and knowledge be shared and be developed actually. We've also had 2 champion visits to the UK, one in 2015, another one due this year. And again, that's to help exchange knowledge, information, to see how we do things here, for them to bring back ideas of how to do things back at Mirembe as well. And it's generally to kind of keep building the partnership and the relationship as well. Next slide. Thanks, Chris. I'll be very brief as we've only got 2 minutes left. So, Chris, would you want me to just sort of move on? I think the challenges are self-explanatory there.
Okay, that's fine if everyone's all right with that. Okay, so the other component that we're going to talk about today is the income generating and skills development scheme for patients. And we've been working with a local NGO in Tanzania called Basic Needs Foundation Tanzania. And we are expected to develop 2 projects. We've managed to work on one so far, which is the craft work project, but we're also starting another one for soap making. What we've done so far is that the project around the craft work and soap making has been agreed with the staff and the patients. They're the ones who actually generated the ideas around that. 49 patients have been involved in the craft project so far, and some of them have been trained up as trainers of other patients. Often they're the people who are peer support workers. The main project leads are the occupational therapists, but there is support from lots of other staff. They actually exhibited some of the products of the work that they've been doing at a governmental exhibition in Dodoma last year. And a lot of people said, oh, well, we really didn't appreciate that patients at a psychiatric hospital could do such good work as that. So it was quite a stigma busting. What they've been able to do is actually use the profits that they've made from this to replenish their supplies, but it also helps to enable patients to be discharged home, because often they don't have the money to get home again. And there's been quite a lot of involvement from the peer support program in that. Our work with basic needs has been, let's say, difficult at times. We engage with basic needs because they've got a considerable experience of working with income generating projects, and we had previous discussions with them in November 2011 and 2014, and we agreed to sort of work with them, and they came to Mirembe Hospital to help with doing some training and to get some of the initial supplies that were needed. But the last thing that we heard from them was back in November and December of last year, after agreeing that the next project was going to be about soap making. But then the person who was our contact there went off the screen completely, so we had no contact with him, either through emails or trying to phone him or any communication at all, and likewise Mirembe had no contact with him. So we felt that this was a bit of a problem, because Mirembe rely on basic needs for a number of different things. So in the beginning of June, I happened to go over to Tanzania for a wedding over there and managed to talk to the president of Basic Needs, and we've managed to get a new representative from Basic Needs as one of their board members to take over the project. So the challenges that we've had with with this project is that essentially Mirembe don't have the commercial expertise to run an income generating project, and so we've been reliant very much on basic needs to do that. They are needing to develop a local sustainable market over there, and often that is involving staff from the hospital getting involved in that. So that's an extra challenge given their limited resources that they've got at the hospital. Obviously, to keep things going, there needs to be enough profit which is being generated by that. So it's partly about the pricing and the marketing of their products to enable them to actually create an income from it. There's very limited space at the hospital, or has been limited space at the hospital to accommodate the project, so they've been looking at different ways in which they can have a bit more space, and that seems to be working out now. There are obviously a number of issues around health and safety for any work-related project, so that needs to be looked at. And because it's an inpatient-based service, there is an issue about actually sustaining a capable workforce, because when people are getting well, they're being discharged. And we've also had some problems at our end in the UK about making sure that their invoices are actually being paid, because our invoice paying system is actually outsourced to a company that we have very little control over. So the future for the project is that what we want to do is actually develop a community arm for the project, and we were hoping to get that funded through a recent funding application, but we were unsuccessful in that. We need to create local markets in Dodoma. We need to look at how individual patients, when they're being discharged, can actually act as individual entrepreneurs. And there are a few patients who have been discharged who provide a very good example of that. We need to have more and greater service user involvement and giving responsibility to the patients, and that's where the community arm could work really well. And there is all sorts of ideas about developing other projects, and these are just some examples. But in order to get them working, we need to have some startup funding. So that's our presentation, and these are my contact details if you need them. You can always send those to you. And this is the Mirembe Rocks. Thank you very much.
Thank you very much to Chris and Claudine for your presentation. It's been really fascinating to hear about your current project. So now I'd like to present Dr. Murali, a consultant psychiatrist at the CSI Holdsworth Memorial Hospital in Mysore, India, and Paul and Steve from the Faculty of Health and Social Care, Edge Hill University. So their partnership has been implementing work on mental health assessment and treatment intervention following suicide attempts in southern India. So I'll hand over to them now. Hello? Yeah?
Good afternoon. Yeah. Can everyone listen to me?
Yes.
Hello?
Hey. Yes, Murali, we can
well,
see your screen.
To start, yes. To start with, I would like to extend a big thanks to the Tropical Health and Education Trust for having supported us not just through the grant but with a wide range of resources and support mechanisms, but for which this really innovative, one of its kind and first of its kind project to enhance the role of nurses, general nurses in assessment and management of self-harm survivors would just not have been possible. And we extend sincere thanks to both Steve Jones and Paul Keenan, our friends and colleagues from Edge Hill University, but for whose advice, support in all manners, this project would not have been successful. For those who are not aware of, India is officially the suicide capital of the world. The scale of the problem is much severe in South India, where our hospital is currently based. The health services themselves are predominantly geared up to provide physical health interventions and services. There is a really very limited mental health services and of that's available, all of it is predominantly hospital-based service with no community services at all. Roughly in this region, with about population of 250,000 people, we get about 8 to 10,000 young men and women attempting self-harm each year. So that's a massive scale of problem. To put it in context, we are losing more men and women to suicide than road traffic accidents. One of the predominant methods of self-harm around here is pesticide poisoning, and the survival rates are really low because of the lethality of the medicine or the poison. And most people who, in fact all of them who take pesticides really need support with ventilators and very sophisticated and advanced physical health care, which is not generally available for free. And then it puts families under much greater degree of stress because limited finances, poverty, debts, crop failure, these are the sort of drivers which people often report as one of the reasons for self-harm, and immediately after discharge they really get no support whatsoever. And in fact, the situation is perhaps much more worse when they are on the wards where all interventions, assessment and treatment are geared towards physical health problems, and very rarely a self-harm survivor would get a thorough mental health assessment, a psychiatric diagnosis, intervention and support following discharge. It is also compounded with enormous social issues which are like stigma, lack of employment, lack of finances, and inability to pay the hospital bills, etc. And in India, any attempt to self-harm is a medical legal offense, so they would also have to face the consequences of the police visit and perhaps a court case for them to attend, which brings in a lot of shame to families. So one of the things we thought in collaboration with EDGIL was to look at the role of nurses in enhancing the mental health service delivery for deliberate self-harm survivors. And the challenge was that we wanted to ensure the mental health needs of the survivors was met and more appropriately be delivered by people who are not specialists, because there aren't many specialists around, and that was a big challenge. And the challenge was adequately met by taking an approach of education and training. We believed that if the general nurses were trained and educated with appropriate training materials and resources, they would themselves be skilled and competent enough to conduct mental health assessment of survivors, but also try create a cohort of nurses who would then go on to train other nurses in conducting such mental health assessments. So there was an existing partnership with EDGIL University, and the initial scoping visit in 2012 clearly identified a big unmet mental health gap among the mental health survivors, mental health gap for the deliberate self-harm survivors. So we then conducted a knowledge and attitudinal survey of nurses, and no surprises, the education levels were low and they had very negative attitude towards the survivors. Then we approached the TED to support us with a grant for partnership for developing a nurse education and training package. That the challenge was developing educational resources which were culturally appropriate, which could be delivered locally, and which would also be received by nurses with good potential and feasibility to translate it into clinical practice. So our long-standing collaboration and several visits by EDGIL staff to Mysore, and the interaction with nurses, and also observing how nurse curriculum was delivered, helped us develop a very good training module which included conducting mental health assessment, communication skills, knowledge and training, the medical legal aspects, a diagnostic assessment, and supporting families and caregivers of the survivors. We also developed an online support for nurses, which unfortunately did not work well, not because of the lack of availability of the internet, but it was predominantly the culture of learning. E-learning does not exist really. So we developed a wide range of training materials which included didactic sessions training with the use of materials, post training sessions were making it. Last round we trained about 100 nurses between 2 hospitals, and it was very successful. Further to which we had at least another 4 rounds of training in which about 25 nurses attended. We created a cohort of about 10 nurses drawn across the disciplines, predominantly nurses and psychologists, who were then kind of developed. There was the skill development process to look at how they actually go on to be trainers and how they would carry on providing training for other nurses. I would arrange fortnightly steering group meetings with them, and frequently we would have input from the HL staff. And one of the key things was it's a big change in India for nurses to be seen at the heart of any delivery of interventions or training. It's predominantly seen as something which is led by doctors and managers. We are very pleased to announce that the Train the Trainers program is very successful. To date, we have about 10 trainers in Mysore who have continued to deliver the Train the Trainer sessions, and we have trained over 80 nurses in conducting mental health assessment for the survivors of self-harm. The challenges, I think I've already mentioned. One of the main things was issue of power, how doctors would see nurses as the key clinical leader, and of course a lot of clinical and cultural credibility. It was not about us, but actually it was doing to them. Getting mental health issue a priority was one of the major challenges, and the biggest challenges of all was nurses in India do not get any time off for training. So we had great commitment from directors of both the hospitals, with the hospital in Mission Hospital, our hospital, and nurses were actually released for 2 days of training, which was a big achievement. The other issues are very much like my previous presenter. The challenges, I think, are universal in a low and middle income country. Physical space, there was rapid turnover of patients, limited IT knowledge and access for nurses. There was a quick turnover of staff, the increased number of referrals to psychiatry, and also securing additional funding to continue the work. So in terms of what we have eventually achieved is we currently have a module of brief mental health assessment which all nurses administer to mental health survivors. As a consequence, the referrals to psychiatrists has increased, the number of psychiatric diagnoses that are made has increased. The nurses now take on a bigger and a better role on advising the deliberate self-harm survivors about their mental health condition and also encouraging them to comply with psychiatric medication. The hospital has also set up a mechanism of ensuring a register where all of them get registered, and there is at least one follow-up call following discharge, just asking them if they were doing well and if they were still feeling suicidal. If so, they would be encouraged to return to the hospital, and our hospital provides free assessment and treatment for all deliberate self-harm survivors. We have a very lively, competent group of trainers who are continuing to train, and they are very thankful to TED for having provided this opportunity for themselves. And one of the major outcome about this is we really kept the patient needs at center. The whole program was responsive both to the needs of patient and nurses, and also the way the services were delivered. So currently, as I've highlighted, we have a register for deliberate self-harm survivors. We have a very good educational and clinical resources. Thanks for the HL colleagues. For nurses now, the role of nurses in the hospital has enhanced. The staff, the deliberate self-harm survivors have better access to mental health services, and our work in this area is well recognized in Mysore, and we get repeated requests by various others in the region and also from out of the state to come and learn as to how they can learn from us to deliver this. And we have had some good scientific outputs from the ongoing project, and the TED grant has strengthened the partnership in Mysore, and it has made a real difference to many of the deliberate self-harm survivors and their families. We used a mixed method model for evaluation, both quantitative and qualitative. The interviews, questionnaires, etc. were used, and it was very clear that the knowledge levels of nurses had increased. There was a change in practice, both in terms of documentation and increased number of referrals to the psychiatry department. Deliberate self-harm survivors, more than 90% of them, compared to a previous of about 10%, are now receiving mental health assessment. And we have really empowered our nurses, and we now believe that not just nurses, but primary health workers like ASHA workers in the community should also be able to do this, and we are thinking of going for other grants to support this. And the feedback from the survivors themselves has been very humbling. They felt they were valued, they felt they were listened, and they felt that actually they were able to share their distress and some of the thoughts with the nurses. And they also felt more open and confident that they can actually come back to the hospital if they were feeling suicidal. But above all, I think they have also realized that there is a service available which they can utilize if they were feeling depressed or suicidal or having any other mental health problem. The management support has been extremely good, and much to our surprise, we have had excellent input from management support team from both the hospitals in Mysore, and the management support from Edghill University was excellent. I think that's the end of our slides, and I have not really gone into some of the challenges which are very much similar to the previous presenter, and in fact we have had lots of difficulties getting the invoices paid due to various reasons. Thank you very much. Thank you.
Thank you, Mali, Paul and Steve. Your partnership has clearly achieved a lot over the past few years. So now I'm just going to switch the presenter screen to Alison so you can prepare while I just introduce your presentation. So our last presenter today will be Dr. Alison Hall, Honorary Consultant of the Child and Adolescent Psychiatry and at the East London NHS Foundation Trust, and Dr. Godfrey Zari Rukondo, Head of the Department of Psychiatry at Mbara University, Uganda. So their partnership is supporting the transition of child and adolescent mental health training at the University Accredited Diploma course embedded at Uganda's Public Health Service and extended into the child health at Butabika Hospital in Kampala, which is the National Psychiatric Referral Hospital for Uganda. So now I'll hand over to Alison and Godfrey for their presentation.
Can you hear me? This is Alison here. Godfrey is on the end of a phone in the Royal London Hospital, where he's here for a very short visit, luckily, and he's going to answer the questions. So I'm going to do the main part of the presentation. I'm not going to cover monitoring and evaluation because I did an earlier presentation in April, so that's available on the website. So I'm going to give a little bit of the background to our two projects that we've had funding from THET for. Firstly, our link has been going now since 2004 and started off as a partnership with the Butabika National Referral Hospital, which is really the cradle of mental health in Uganda, because most people even now train there. And the link focused on capacity building of Ugandan mental health services through collaboration in training and development, but particularly we were involved in the development of specialist mental health services, developing multidisciplinary working and peer support work, and developed our links across Uganda. Although there are other mental health projects in Uganda, we also reached out particularly to Mbarara, where this Dr. Godfrey Rukondo is based. So just to give you a perspective of where we came from, we started doing work in child mental health back in 2006, when there were 26 psychiatrists in the country, but only one had trained in child psychiatry, and she was about to retire. There were no other mental health professionals trained in child mental health. The children were treated as mini adults. They were rarely seen separately from adults, and over 80% of the children were actually presenting with epilepsy, which, like other developing countries, becomes under the province of psychiatry rather than pediatrics. At Bouteflika Hospital were wards with about 100 patients, and the children were not identified. They were just lost on these wards. And a couple of case examples, a 13-year-old boy was locked up on the forensic ward, and his story was he killed 5 children. He'd actually killed 1 child in anger with a hoe, but he kept trying to escape, so he was kept locked up. There was a very sad girl with learning disability and no language who had genital warts and was clearly a street child who'd been abused. And those were the kind of patients that we found as we assessed them. So from 2006 onwards, we did some training from the link, both for staff at Bouteflika and Mbarara Regional Hospital, which also has a medical school there. And also we had a network of psychiatric clinical officers, which is a grade between nurses and doctors who can prescribe, which really provided the backbone of mental health care in Uganda. We brought 4 people over for Commonwealth Fellowships in the UK, including Dr. Godfrey, and the other area of work was separating the children from the adults at Bouteflika and developing a specialist children's ward. But I think most importantly for the development of our training program and achieving THET funding was back in 2008 we gathered the professionals who were interested in child mental health, and some of that came from having received training from us, with representatives from Makerere University in Kampala and the Ministry of Health. And we developed a joint strategy which was aiming to develop specialist mental health services for children in Uganda, and to develop the possibility of having dedicated services for children both in Kampala and regional level. And then the idea was then that in those places they would develop a multidisciplinary workforce who would be able to train people at district level. The multidisciplinary aspect was challenging because even at Bouteflika there was an OT and doctors, nurses and PCOs, but very little in the way of any other specialties. That has changed, but nationally it's still a huge issue. We reviewed progress with the Ministry of Health and the university, and this provided the groundwork to getting a funded project from THET. So the first project was the development and implementation of a multidisciplinary training program in child mental health for mental health professionals, and that was funded to the tune of £150,000, including a long-term volunteer, which was really key to the development of this training project and to the subsequent one, which we were still engaged in. Our initial partners were Bouteflika Hospital and the East London Trust, and the aims were to develop this training program, which would be continued after our link withdrew. And we hope that the number of children seen by professionals with specialist training would increase. We hope that we would reduce the numbers admitted as inpatients, particularly at Bouteflika, and develop the possibility that children would be seen more locally throughout the country. So Godfrey and I and Dr. Joyce Naluja developed a curriculum which was to some extent based on the senior registrar training which I was involved with at the Royal London Hospital in Great Ormond Street. But the emphasis really was developing knowledge and clinical skills, but making a lot of emphasis on developing experience with children at the workstations to build on what they were learning in the teaching modules. We had 12 teaching modules over 2 years, and the idea of this was that traditionally we found that people in Uganda went off to train or do a degree and were taken out of service, and the services were very, very hard pressed, but also people were not getting clinical experience when they were learning in the universities. So the idea was that people would continue to provide their work and gain experience between the modules. There was 1 week of classroom-based learning and 1 week of clinical training on the children's ward at Bootebeka, which by then was fully functioning as an inpatient ward and an outpatient service separate from the adult parts of the hospital. And we had 3 other training sites which were all had medical schools: Gulu with Dr. James Okello, and Mbarara with Dr. Godfrey, and Malago with Dr. Joyce Naluja. The teaching initially was delivered by 21 short-term volunteers from the UK who were all CAMHS professionals and multidisciplinary. We had 2 long-term volunteers. The first was a clinical psychologist and the second was an educational psychologist, and we all worked with Godfrey and Joyce, who were the Ugandan program directors. So we set off with training the trainers in November 2012, and then at that time the training program was launched by the Ministry of Health, and a representative from the Ministry of Education came to the PCO school, which is where the course is based. And in 2013 we trained 23 mental health professionals, basically in the assessment and management of children, and they were all awarded a certificate, and they came from across the country as I've listed. In 2014 we selected 15, but 2 were unable to continue for different reasons, and the 15 were selected to complete the diploma, which was more intensive training in psychological treatments, and also to train them as trainers and supervisors for the others. The project ended in February 2015 with a big conference. The course was supported by the program directors Godfrey and Joyce, and also a ward manager and a PCO from Bootebeka who we trained in East London. And we provided a lot of electronic teaching, marking of case studies and support for projects from the UK volunteers who'd actually then, or by then, had experience of teaching on the course and knew the trainees. We also had support from Luna Children's Charity for training in trauma treatment, which involved training the trainers in year 2. The course we really wanted to develop multidisciplinary approach, and this was a bit of a challenge because nurses, there was a feeling about whether psychiatrists could be on the same course of nurses, but the feedback we had from the course was that in the end everybody really valued the multidisciplinary aspects and learning from each other. We also emphasized child and family-centered skills. Some people had no IT knowledge at all, so we got people up to speed, so they were even doing excellent PowerPoint presentations. We provided them with modems. The people had clinical placements at some of the other sites as well as Bootebeka, and in doing trauma treatment they went out to children's homes to treat children who suffered abuse, neglect and other serious trauma as refugees. The course also had a strong emphasis on case studies, logbooks, projects which were undertaken in their local environment. I won't talk in detail about the assessment of the trainees, but I've left the slide for you to read afterwards. And we designed the curriculum, which was a mammoth task, and the assessment procedures to conform to university requirements, because during this period we were struggling to get university accreditation. The outcome of the first projects was that there were vastly increased numbers of children seen by professionals with CAMHS training, but there was increased attendance, so that actually there was more children being seen, so they were still being seen by mental health staff without this training as well. The service at Bootebeka did decrease the number of inpatients, but increased again, partly because Malago Hospital was closed for refurbishment. We also increased the numbers of children attending for other conditions other than epilepsy. We were continuing to work on the accreditation. We had 135 professionals came to our CAMHS conference, and we really wanted to include paediatricians, and we were very pleased that 15 paediatricians attended, some of whom presented. At that stage, our work with the Ministry of Health, they'd actually agreed that the diploma would be the qualification required for professionals who would be working in child mental health in the future, and they agreed that there should be designated posts. They also agreed that they needed to develop specialist nurses with a career structure which was not just true for child mental health but was true for other nurses in other specialities as well, and there was no actual pathway for them.
Hi Alison, sorry to interrupt. We just have over 2 minutes, just under 2 minutes, sorry.
Okay, I'll quickly show them, yeah. The second part is really just to show you that the second was a sustainability project, and we increased the partners and we replicated the training program and provided additional training in psychological therapies for our trainers. And we wanted to strengthen the training program and this career structure with the Ministry of Health. And just to give you a picture, on the left are two of our trainers, Florence and Sam, with our group of trainees who are on the course now. And this is some clinical training in Mbarara with Joseph, who's one of our new trainees, and Sison, who's a social worker who is one of our graduates with a young child. The monitoring evaluation is covered on my previous presentation, so I won't talk any more about that. But just to say that we managed to achieve university accreditation after a huge battle, and we have tremendous gratitude to Godfrey and Professor Sam Mailing for that. We managed to recruit 2 child health professionals, but were not successful in recruiting paediatrician because of time constraints, and so that has to be looked at for the future. And we had a very successful stakeholders meeting in June where they actually agreed that the law would have to be changed to allow a career structure for specialist nurses. The challenges were that, as in everybody has this experience of balancing the demands of the course, both for teaching and for attending, with the work responsibilities. And the children are still being seen mostly in adult mental health facilities with lack of separate facilities. And still many of the people who we train still have to provide mental health services to adults and they had difficulty organising separate clinics for children. There are still many children presenting with epilepsy, and it's hard for staff to find the time to develop psychological treatments even for children with epilepsy with other problems. And there are many vacant posts around the country which can be converted to CAMS post in the longer term, but it's a question of the way in which posts are filled and money is provided. And our big worry is achieving long-term reliable sponsorship for the course, and that's our contact details. After that, there's a value for money, some slides which people can read about if they want to look at that subsequently. So thanks very much. Sorry I'm galloped at the end.
Thank you very much, Alison and Godfrey, for your very interesting presentation, and it's good to hear about the achievements that you've made with your partnership. So we've had some excellent examples today of the fantastic work that's being delivered on mental health from all your presentations, and much of this work fulfills what we consider at THET to be the principle of partnerships, or more informally POPs, which I'll just show you now. And they've clearly shown that how these are translating into the success of all your partnerships and your projects. So if you haven't yet visited our website to explore the 8 principles further, please do so. And also we've started blogging about the issues related to the principles, so please keep an eye on our blog page too. So I'm worried that we don't have a lot of time left, so I'd like to open the floor for Q&A. And if you have any problems with your IT, please just let us know, so I will. So yeah, if you have a microphone, you can put up your hand using the little yellow button, and then we'll invite you to speak and unmute. Alternatively, you can type in your question and I will be happy to read that out for you. So yeah, the floor is open to questions, so please go ahead.
David, we've just unmuted you, so if you want to ask a question to the panelists, please go ahead. We should be able to hear you. Okay.
Okay, so yeah, we can't hear David, so does anybody have any questions? So we don't have any questions, but do the panelists, do you guys have any questions for each other or would like to add anything further?
Hi, I just wanted to ask Alison, what were the type of psychological therapies that were taught on her program? Just interested.
I mean, I could answer. I was going to, if Godfrey, it might be better for him to answer since he can talk about it in terms of the relevance there, if he's online, if he's on the phone.
Godfrey, did you hear the question?
Well, I had the question. We looked at different psychological therapies, including CBT, the children's therapy, trauma therapy, individual therapy. So we looked at a number of psychological therapies according to the needs at the time.
Oh, thank you.
Perhaps I could add to that that the biggest challenge has been the amount of time that people have to put them into practice and making them culturally relevant. So, for example, on the family approach, we really have got them used to talking to the whole family and not being able to do any ongoing work, but being able to use interventions when the family comes. Maybe it's only at the first assessment, but trying to get people to come back. And the individual therapy work has been around particularly about helping them to look at children's drawings and communicating with individual children, because often children were not encouraged to talk in the presence of adults in clinics.
Mm.
Behavioral approaches, I think people have put into good practice. There's a lot of developmental disorders in Uganda, so people really have been able to use the behavioral skills in individual, even in an assessment appointments.
Okay, thank you very much for that. We have a question from Kath Snape. She's asking, I'm interested in how epilepsy is managed and if education at population level is being undertaken to differentiate it from mental health. To differentiate it from mental health.
Godfrey can answer that. He's the expert.
Godfrey, yeah.
Of course, we manage epilepsy as a mental health problem because we don't have many neurologists in Uganda. And during the training of mental health workers, there is usually a detailed module on epilepsy. So we manage it just like they will manage schizophrenia and bipolar, because other people are not managing it. And of course, it's a challenge because you are not able to do a lot of investigations to maybe characterize the types of epilepsy. We just use our clinical skills, history taking, and maybe the account of the witness to be able to make the diagnosis.
Thank you very much for that, Godfrey. Any other questions, comments from anybody?
I wanted to ask about the program in India, and particularly where you've been sort of skilling up staff over there to actually work with self-harm. I was wondering whether you had also been doing any work around community education and sort of getting people to know how they can access services before actually resorting to such dire options, really.
Hi Chris, it's Steve here from the partnership. We have so many points that we could do interventions on, and it's interesting that most of us have picked hospital environments for interventions with staff or at most outpatient environments, and it's about, if you like, targeting the most effective use of resources to get the biggest range. that's why we chose hospitals, but it was one when we went to intensive care and we were struck by the amount of people who were ventilated due to pesticide ingestion. And when we worked in accident and emergency, there were a few people coming in per day with accidental pesticide ingestion as their diagnosis. We also were working with the medical model, so we had to start somewhere, so that's why we chose the medical model. But to answer your question, yes, there's clearly a need to work in schools, there's clearly a need to work with parents and teachers. There's a high suicide rate, or harm rate I should say, around about the exam stage of the age of 14 within most states in India. So there are target times for pressures because there's a heavy demand on education, but equally on discharge there are no community mental health teams. The services are reliant on a very limited number of psychiatrists who can see up to maybe 100 patients per morning. So that's why we looked at training volunteers called ASHA workers that Murali mentioned, where you've got the most effective use of resources out in the communities where most of the harm attempts actually occur. So massive intervention opportunities, but we started off with hospitals, but we're aware we've got to target both ends of that.
Thank you.
It's interesting, isn't it? Because I think that's what we're finding with our project as well, is that because we're inpatient based, naturally while you've got a captive audience there, both staff and service users, there's a lot that you can do, but it's about kind of that next step when people leave that inpatient environment. How is all the work that's being done and all the skills that have been shared, and how does that translate into a community setting? Like, that's the biggest challenge I think for all of us in terms of these type of projects when you're in an inpatient setting. And it's challenging because I think mental health in particular and substance use, it goes beyond an inpatient setting, if you like, and actually the better use of resource, time, energy could also be spent in setting up some sort of community networks and all the rest of it. But I guess that needs to be owned by, you know, the Tanzanian government, well, from my perspective, the Tanzanian government and, you know, Department of Health, as well as the work that we do to kind of keep pushing that agenda forward, really. Because I think, you know, a lot of mental health issues and substance use issues, like here, really, they're based in their communities where people come from, and it's about kind of engaging that wider community context into discussing these things further, and that's a bit of a challenge, I think.
Absolutely, Claudine. They're only just beginning to talk about mental health problems and mental illness as we know it in some environments in India.
It's actually culturally eye-opening when you go there, because I previously did some work in Pakistan, well, for several years really, and it's interesting the difficulties they're having there. They're exactly the same as India, which shouldn't really surprise us. But if somebody becomes what we would recognise as, say, mentally ill or suffering from psychological difficulties, it might be 12 to 14 years before they present to what we would recognise as a professional, because they're seen by the local elders, then they go to a shaman, they'd go to a quack, they'd go to the temple. And I'm not decrying any of that. What I'm saying is it's changing that culture. And getting, just allow, and that's why I totally support the ASHA workers who are literally knocking on doors in villages and sort of introducing themselves and seeing if there's anything going on there. Absolutely incredible work they do.
We've just submitted our finance sheet as well to THET as well, and we went over budget by £150 on that because we actually went out to see the ASHA workers. We made opportunity of an afternoon, and that's where we drove 3 hours into the tribal lands looking at next stages for interventions whilst on our last visit.
Can I ask, guys, so the ASHA workers, are they like peer support workers or are they professionals? What's their background?
An organisation, if you Google it for people watching it in southern India, ASHA was set up as a charitable organisation run by a group of doctors over in India, and there are 26 primary healthcare centres recently built in southern India. ASHAs are volunteers, trained volunteers, and they were initially set up to give immunisations, and the government pays them a nominal amount for each vaccination they give, so they get paid by results. But I mean, when I use the word nominal, there are other words for it. Limited.
They're the equivalent of community health workers then?
Yes.
Yeah.
And they wear bright pink, Asha meaning hope in India, but you can't spot to, you can't fail to, meet them. They're on the horizon and it's an Asha worker, but they do knock door to door. They're very passionate and they come from the communities where they actually work within.
Thank you.
Yeah, thank you very much for that and all your presentations today. And please do feel free to get in touch with me if you have any feedback or comments about the session. I'm just going to share my screen so you can. Oh, it's already here. So you can see my email address there. And also, so lastly, I'd like to thank everyone that's registered and very much for attending our webinar today. We hope this has been of interest to you, because it definitely has been for us. And of course, thank you very much and for your detailed and insightful presentation. If there's anything else to add, I'd like to, All right, thank you very much.
Take care. Bye, everyone.
Thanks, everybody.
Bye. Thank you.